Добрий вечір всім. Будь ласка, пані Оксана і пан Андреа, покажіть мені, що ви мене чуєте, щоб ми перевірили, що ви мене чуєте.
Вітаю, пані Катерино. Чуємо, але ще не бачу.
Добре. Тоді будемо починати, і тоді, пані Оксана, вам слово для того, щоб ми розпочали сьогоднішній ефір.
Дякую, пані Катерино. Я вечір добрий. Намагатимусь швиденько привітатися, поки маю світло. Його вже мали би відключити, але якимось дивом воно ще досі є, поки є стабільний зв'язок. Отже, доброго вечора, шановні наші партнери і учасники, а також технічна команда, яка забезпечує нашу сьогоднішню зустріч. І я вас вітаю на проєкті, який є спільним від Всеукраїнської програми ментального здоров'я та як, ініціативи першої леді України Олени Зеленської, дитячого фонду ООН UNICEF, спільно з нашим улюбленим партнером, Європейським товариством дитячої та підліткової психіатрії, яку очолює професор Фехерт. І професору Фехерту особливі вітання і особливі слова вдячності, тому що він з нашою командою, пані Катерино, вже другий рік. Ви сьогодні матимете розкриття теми щодо посттравматичного стресового розладу у дітей та підлітків, яка в Україні аж занадто міфологізована. Тому для нас, для всіх, для всієї спільноти фахівців надважливо бути в контексті від дефініції до доказових методів як діагностування, так і лікування, супроводу, терапії і так далі. Саме тому сьогодні маємо найкрутішого експерта, професора Андреа Danese, дитячого та підліткового психіатру Інституту психіатрії, психології та нейронаук Королівського коледжу Лондона, ад'юнкт професора Єльського центру дослідження дітей. Я впевнена, що сьогодні будуть сотні запитань від наших фахівців, що, пані Катерино, давайте на це розраховувати. І дуже сподіваюся, що 1500 учасників, які були зареєстровані на цю зустріч, все-таки зможуть доєднатися попри відключення електроенергії, але ми точно знаємо з вами, що потім це можна переглянути в записі. Я поки говорила, ви налаштуєте переклад, бо зазвичай дуже багато про це запитань по ходу вже нашої зустрічі. І зазначу, що оскільки тема ПТСР є не лише міфологізованою в Україні, а й неймовірно затребуваною серед фахівців, я скажу, що для фахівців, які працюють з дорослими, як цивільними ветеранами, ветеранками, так і діючими військовослужбовцями, на YouTube-платформі «Тияк» є вже 6 окремих таких вебінарів, лекцій на тему ПТСР, тож ви можете так само переглядати і дізнаватися все те, що ви хотіли на цю тему знати. Отже, нам гарного продуктивного вечора і, дорогі наші фахівці, ви фантастичні, неймовірно вдячні вам не лише за те, що ви робите те, що ви можете робити там, де ви є, за ту відданість, з якою ви це робите, а ще й за бажання вчитися, дізнаватися, дискутувати, ставити складні питання. Бережіть себе, і нехай нам буде сьогоднішній вечір світлим, а головне мирним. Подбайте про свою безпеку. Дякую, пані Катерина. Окрема вдячність перекладачам. Для них це завжди такий челендж.
Дякуємо дуже, пані Оксана. До того, як ми почнемо, декілька організаційних моментів. Мене звати Катерина Булавінова, я медична експертка UNICEF в Україні. Я залишусь сьогодні з вами до кінця цього ефіру, і в кінці я буду зачитувати ваші питання, які перекладачі будуть перекладати, як ми це робимо кожного разу. Ми наразі знаходимося на 3 площадках. Це Zoom, це YouTube і це Фейсбук. На Zoom нас вже 312 людей наразі, на YouTube 4, на Фейсбуці 8. Будемо дивитися, що буде далі, бо зазвичай люди доєднуються потім. Для тих, хто цікавиться, потім в записі в нас буде як версія з перекладом на українську мову, який роблять наші перекладачі, також і версія в оригіналі для тих, хто любить дивитися англійською. І для тих, хто приєднався до нас перший раз, є ціла папочка всіх попередніх наших вебінарів, теж в 2 варіантах, як на українській мові, так і на англійській мові. Ми дуже дякуємо професору Andrea Danese, який дуже зайнята людина, але знайшов час в вечірні часи, в неробочі часи, для того, щоб з нами побути. Ми йому за це дуже вдячні. А всім вам дуже вдячні, що ви попри всі складнощі, попри те, що холодно, виключають світло, у вас є купа різних справ, я це знаю по собі, в мене теж дуже надовго виключають світло, я біжу до цієї стиральної машини або до якоїсь ще машини, щоб щось зробити, що ви замість усіх цих важливих справ сидите з нами в цьому вебінарі. Тому бажаю нам плідної роботи і прошу операторів вивести на екран Andrea і презентацію Andrea. І тоді ви побачите мене в кінці, коли будемо задавати питання. Прошу.
Thank you very much, Katya. It's an incredible pleasure and honor to be with you all, and to join again the webinar series hosted by ESCAP, so the European Society of Child and Adolescent Psychiatry, as well as the Ukrainian government and UNICEF. And today, as we heard, I will be talking about PTSD, post-traumatic stress disorder, in young people. A few disclosure before I begin, and the disclosure really are about highlighting some incredible groups and networks that I am part of. Katya already mentioned ESCAP, where I act as General Secretary and Chair of the Academic Division, and ESCAP also hosts a number of very helpful resources on child and adolescent psychiatry that may be accessed over the internet. And so does ACAM, so the Association of Child and Adolescent Mental Health. And this evening, I'm going to discuss several topics that relate to PTSD in young people. First of all, we will start with some definition and into considering that even responses to extremely traumatic events can be normative. That is, we can observe some responses in children and young people that are understandable in the context of those experiences and do not necessarily amount to mental health disorder. Of course, this is important so that we can differentiate those normative responses from what is instead trauma-related psychopathology, so a disorder related to those experiences. I will cover key facts related to PTSD treatment and the evidence base for trauma and PTSD treatment. And finally conclude with some warnings around detection of PTSD specifically. So to begin with, and considering these normative responses to trauma, as I said, I wanted to begin by sharing what we often use as the medical definition of trauma. Trauma is a word that is often used, often in the right way, but also as it has gained acceptance in common parlance. Different people might use the term in slightly different ways. And so it's very important that we as professionals, but also as members of the public, are clear about what medics and clinicians mean when they talk about trauma. And for trauma specifically, we mean the experience of some extraordinary events in many ways, and not necessarily the psychopathological consequences of trauma. And I will come back to this point in a minute. Trauma is not just the experience, but we tend to use a very narrow definition of trauma in clinical practice as well as in research. And a commonly used definition of trauma is this one from the Diagnostic and Statistical Manual. So this is the classification manual devised by the American Psychiatric Association. And as part of the diagnosis of PTSD, we have this first criterion, or criterion A, that really identifies for medical professionals what trauma is. And that is an experience that is occurring to a person who was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence, right? So you see, it's a very narrow definition of trauma compared to, I think, what many people might consider more generally. And it focuses on experiences that can be measured quite clearly, that can be operationalized quite clearly. And this is indicative of the scope of the DSM-5 and other diagnostic manuals. That is, they don't necessarily maximize the validity. They don't maximize the inclusion of all possible experiences, but they maximize the reliability. So the ability of different professionals, of different people to understand each other when they communicate. And these are experiences that can be very clearly measured and shared. And that's why they are included in the DSM-5. We see in the DSM-5 that trauma can be experienced directly. That is, person is exposed to the trauma personally. It can be witnessed, so the person is observing others who are exposed to trauma. And we also have network traumas. That is, people don't necessarily observe the trauma, but they learn about the trauma. They could learn about the trauma that relatives or close friends have experienced. Or they can also learn about it indirectly as in the course of their professional duties. So thinking, for example, about medics and first responders. I will stress again, this is a narrow definition of trauma. There are ongoing discussions as to exactly where the boundaries between traumatic and non-traumatic experiences should be placed, but this is what we have at the moment. And I will stress again that by trauma, we intend to discuss the experiences and not necessarily the psychopathological consequences of these experiences. And this distinction between experience and outcome, if you like, is really important because it recognizes that despite the very challenging experiences, there is very important proportion of individuals who are resilient. So they do not show the negative outcomes that we often think as associated to these experiences. All right, and so this is very briefly the definition of trauma. And there are many streams of research that, for example, challenge and try to expand that definition in different subgroups. And particularly, we're very concerned that children and young people who are neurodivergent, so for example, they are on the autistic spectrum, may have experiences that trigger PTSD reactions that are beyond the ones that are listed here. So, as I say, this is the current definition, and much work is ongoing to elaborate on this current definition. Now, once we are clear about what we tend to identify as trauma or traumatic experience, then we can think about what the outcomes of these experiences might be, of course. And as I said, it's really important to identify and discriminate normative and abnormal responses to trauma. And for the mental health professionals connected tonight, this is really an exercise that in many ways could be conceptualized as similar to the exercise that we do, for example, in assessing children and young people with suspected diagnosis of ADHD, so attention deficit and hyperactivity disorders. What I mean to say with that is that we need to develop a certain expertise and understanding to discriminate what is normative and what is developmentally expected and appropriate from what is abnormal. Yeah. And again, when we focus on the more normative responses to trauma, we can see that they can be varied in nature. And it is very common after traumatic experiences to see children and young people reporting any, and in fact, several of these symptoms. So after a traumatic experience defined in the previous slide, we see that many children may become more clingy, tearful, upset, tired, avoidant of discussing the details of the trauma. They could become inattentive. They could persevere in reporting details or playing or reenacting the traumatic experiences. And they may even report some physical health concerns. So they may report, for example, stomachache or headache. So somatizing responses. And these are common and normal emotional responses to trauma. And they can subside within a few days or months in most children. When the symptoms persist for more than a month and or impair the child's functioning, so when the child is impaired, for example, in their performance at school or in their ability to socialize with peers, children may then meet criteria for a diagnosis. And of course, PTSD that we will discuss tonight is one example of the diagnosis that we can make in the context of traumatic experiences. So we have thought about definition of trauma. We have thought about what are the common responses that children and adolescents have in the context of trauma. And now we are going to start considering what are the types of trauma-related psychopathology. So the types of psychopathology that are triggered by trauma, or if you like, the types of psychopathologies that are increased in prevalence in groups of children and adolescents who have had traumatic experiences. And of course, the paradigmatic experience that we think of in the context of trauma is PTSD, or post-traumatic stress disorder. And the name itself has an interesting story. It was the concept of PTSD, of course, was developed in veterans largely after the Vietnam War, and has been developed as a concept and also has been applied to children and adolescents. Now, PTSD in its name identifies that the condition is post-traumatic, and there is some stress reaction, right? And often people consider that really is a condition that is eminently linked with the traumatic experience, and that the crucial mechanisms that are related to PTSD have to do with the traumatic experience. But more and more, as I will discuss throughout the presentation, what we are learning is that although, of course, the experience has to be there, what really is driving the risk of PTSD and the maintenance of PTSD is the individual response to that traumatic experience, which we can then try to modify through different types of interventions. So what we try to modify, of course, is not the traumatic experience which has happened before we consider a diagnosis of PTSD, but the response to that experience. So what is driving this condition, and really the key pathological component in PTSD, is not necessarily the experience itself, which has to be there, but does not determine PTSD in each person who is exposed to trauma. What is driving the risk of PTSD is a disorder of memory. Yeah. So PTSD is, of course, related to traumatic experiences, but is primarily a disorder of memory. So what we see in the context of PTSD is that unlike memories of pleasurable or neutral events even, we lose the ability to control how our memory unfolds. So in other words, when we think about experiences that are positive or negative, we're typically very able to control our ability to recall. So we decide when we want to trigger a memory. So we might think back about a nice time we had with a friend or with a family, right? We are in full control. We decide that we want to start off that memory. What can happen in the context of negative traumatic experiences is that we lose that ability to control our memory. And so the essential element in the diagnosis of PTSD is the presence of the unwanted, or we call them intrusive, memories of negative experiences. This is really the crucial aspect, and in the absence of these re-experiencing symptoms, we cannot make a diagnosis of PTSD. So what we need to hear is that children and adolescents do not feel that they have control over their memories, that they have memories about these negative experiences that come up in their mind when they don't want them, when they are potentially engaged in other activities. Importantly, these memories can occur at any time of the day, but they tend to occur particularly often when children and young people are not engaged in activities that might distract them from the memories. So typically, we hear that one of the worst times for these memories is when they're trying to fall asleep, right? When they're trying to avoid any distraction, when they try not to think about other things, they're just trying to relax. And that is the time when often we hear the memories are most intense and impaired. Now, I said that the memories can occur at any time, but also it is true that more often they occur in the context of triggers or contextual reminders. These are things that remind children and young people of the context where they had that traumatic experience. Typically, these triggers are sensorial stimuli. So they may tell us that they have seen something that looks like the context or the person that they associate with the traumatic experience. They may tell us that they have the memories or tend to have the memories more often when they hear certain noises. that remind them of the traumatic experience. Or even, and that's a very powerful trigger sometimes, when they smell specific smells in that environment. Now, another typical feature of the memory disorder that we have in PTSD is that these experiences are felt as very vivid. They're full of sensorial characteristics, and they may be experiences in a peculiar way so that the child or young person loses awareness of time. So they often report that it may be as if the traumatic experiences were happening again. And this is a continuum where there may be a description of very vivid images, for example, that come to their mind, and to one extreme. And at the other extreme, we have frank dissociative experiences, where children seem to blank over other things that they were doing while they're having the memories, and lose track of time, so that when the memory stops, they might feel unable to continue the activities that they were doing. So all this happens typically during the day, but also these memories can be experienced at night in the forms of nightmares. So again, these symptoms that I just described to you really identifies this cluster of reliving or re-experiencing symptoms of PTSD that have to be there in order to give a diagnosis of PTSD. Now, these, as I said, are very distressing memories. And so, of course, it's natural that children and young people don't want to have them. And therefore, another cluster of symptoms of PTSD has to do with avoidance. So that means that children and young people engage in maladaptive coping strategies that may be helpful to reduce distress in the short term, but contribute to maintaining the traumatic memories over time, because prevent them from elaborating and integrating them adequately. Now, the avoidance could be related to overt strategies. So by that, I means that it could have to do with observed behaviors related to avoidance, for example, of contextual reminders. That is, in the simplest example, if a child was involved in a car traffic accident, then the child might try to avoid going again onto a car. But we are aware that many of the avoidance strategies to reduce the occurrence of the memories may be also covert. So not things that we can necessarily observe, but experiences that are internal to the child and young person that we really need to keep in mind. And so, for example, the children and young people may just try to keep themselves busy with different activities at all times, or they may even have mental routines, for example, counting, that in some cases could be quite similar to the compulsions that we see in obsessive compulsive disorder. Now, as I said, these avoidance strategies are maladaptive and maintain the memories over time. So because these memories continue to be there despite the end of the experience, what we also see in PTSD is that, again, despite the end in most cases of the traumatic experience itself, the child or young person report ongoing perception of threat that is really driven by these intrusive and distressive memories. The other thing that we want to examine and assess for PTSD is the presence of negative impact of the distressing memories on attention. So, for example, children often report that because of the traumatic memories, they cannot really focus at school. They cannot complete tasks. they cannot engage with their friends and peers because they are disturbed in their attention by the memories. And the memories can also impact on emotion regulation. That is, children, particularly in the context of the traumatic memories, may become particularly irritable and therefore may have quite intense and potentially violent reactions in the context of minor frustrations. So this is really the clinical description of PTSD, highlighting here the three dimensions that we look at for the diagnosis of PTSD and highlighting what we want to assess when we meet with children and young people who had traumatic experiences. And I describe this in detail with this clinical description, but I'm also happy to pass on some slides that give you some other references and structure for clinical assessments, should this be helpful. Now, I wanted briefly to also mention that in addition to PTSD, we now have an additional diagnosis of complex PTSD. These are subtypes of PTSD, a subtype of PTSD, whereby not only children and young people will have these experiences, so the ones I just mentioned of re-experiences, avoidance, and sense of threat, but in addition to them, they will also have other types of symptoms that broadly are described as disturbances in self-organization. And they identify challenges to normative development in three important areas. So the social development is identified by disturbances in interpersonal functioning. The self-development is identified in challenges with negative self-concept, and emotion development is highlighted here with this description of affect dysregulation. So complex PTSD is a new interesting diagnosis, is a subtype of PTSD. So it's important to remember that it requires children and young people to meet all the criteria for PTSD and these additional criteria. So it's a subtype of PTSD. And I should highlight that really its validation so far has mainly been based on studies in adults. And therefore, the concept of complex PTSD in children and adolescents at the moment is not as well established. Now, this is, again, the clinical description of PTSD, but it's also important to, for a good clinical understanding of it, to understand its epidemiology, so its prevalence and correlates. And so I will show you some slides that refer to a study, the first epidemiological studies on PTSD in the UK, based on the ERISC longitudinal twin study, which is a population representative birth cohort that was started in England and Wales here in the UK in 1994-95. That included 2,232 twins that were followed up to age 18. And you see that the study has very high levels of retention, which is essential for this type of work. So that means that 93% of participants that were enrolled at birth were seen again at age 18. It's very important because, of course, there are good reasons for why people drop out of longitudinal studies. And those reasons often have to do with psychosocial difficulties, including trauma, and psychopathology, including PTSD and other types of psychiatric disorders. And I will show you some data related to the mental health assessment that we have undertaken when the cohort was aged 18 years. So first of all, the prevalence of trauma, again, this is a population representative cohort in the UK. And what you can see that even in peacetime in the UK and using, I should highlight, again, the narrow definition that DSM-5 gives us for trauma. So with all these caveats, still the prevalence of trauma exposure by age 18 is quite high. It's 31%. The second question, of course, is what is the proportion of trauma-exposed young people who then develop PTSD? And what we found in the study is that about a quarter of them will have PTSD by age 18. So that amounts to about 88% of the population, and again, 25% of those exposed. Now, you might think, of course, that this reality is quite different from the reality in Ukraine, and that is true. And so we can learn from this kind of data and extrapolate what we might expect. And we can then see how that matches with the epidemiological studies that have been undertaken in Ukraine. So by that, I mean that the prevalence of 8% of PTSD is a function of the exposure that we have in the UK. If we keep the same level of risk, so 1 in 4 individuals exposed to trauma, and we consider a situation where most or all of the samples is exposed to trauma, then instead of 7%, 25% might develop PTSD. We can also consider that certain types of trauma, as you will see, are more strongly associated with risk of PTSD. And that means that if we increase the proportion of trauma-exposed individuals with PTSD, then we may have very high rates of PTSD in the population. So this really challenges the notion that PTSD is a comparatively rare condition, particularly in children and adolescents. And we see and we believe that depending on the context and the type of trauma and vulnerabilities, the rates could actually be very high, and therefore it's important to promote education and treatment for this condition. But we have focused on PTSD, and the other important point that we have learned by doing epidemiological studies is that PTSD is only one on many outcomes in children who have been traumatized. So in this case, I'm showing you the prevalences of several different types of psychiatric disorders in the e-risk sample. That's combining those who had and those who didn't have trauma exposure. And what you see is therefore that some usual suspects are quite high in prevalence. And for example, major depression and conduct disorder here are very high in prevalence. Now, what is more interesting to our discussion is to observe how these prevalences change once we focus our attention on the subgroup of participants who reported trauma exposure. So what you can see here is that we have an increase in the risk, in the prevalence of most conditions in trauma-exposed individuals compared to the overall populations. And that PTSD is not the only conditions, of course, that is increased in prevalence in trauma-exposed children and young people, and also not the most frequent, whereby conditions that have higher base rates, like depression and conduct disorder, also have higher rates in trauma-exposed individuals. So the clinical learning point is when we assess children who had traumatic experiences, we must focus on PTSD, but we must also undertake quite a broad assessment for a number of other conditions. We can then see how the prevalence of different conditions change further focusing on the subgroup of participants who not only had trauma exposure, but also developed PTSD. And what you see here again is that the risk is elevated across the different disorders. So much so that more than half of individuals, young people with PTSD, will have a comorbid major depression disorder. And if we bring together all these diagnoses at once, what we see is that more than 3/4 of children and adolescents with PTSD will have a comorbidity. So this basically is telling us that even after we have made a diagnosis of PTSD, we need to continue with a broad assessment of psychopathology, and we should expect quite a complex presentation when we identify PTSD. That comorbidity really is the rule. It's not just about psychopathology, but both in terms of the trauma-exposed young people and those with PTSD, you see that they have very high levels of self-harm, suicide, and violent offenses, as well as NEET, that is, not in education, employment, and treatment. And this really highlights the need to treat PTSD to avoid and mitigate these outcomes. Now, when we make an assessment for PTSD, we need to be careful in considering which type of trauma we are assessing for. And so these are, if you remember from the DSM initial slide, the different types of trauma that people may experience. So direct interpersonal, assault or threat, witness interpersonal, but also you see accident and illness and network trauma. So we have basically these 5 types of traumas that could be experienced. And you see that if we ask which type participants with trauma exposure have experienced, these are quite uniformly distributed. So they have roughly the same prevalence. We can also look at how the prevalences change in children and young people who develop PTSD. And to the extent that the prevalences change in PTSD, we can conclude that certain types of trauma are stronger risk factors for PTSD than others. And this is what we observe. If we focus on PTSD, we see that there is a greater proportion of direct interpersonal trauma, so assault or threat, that is present in PTSD, over, for example, a reduction in the exposure to network trauma here at the bottom. So what we interpret from this is that certain types of trauma, and particularly traumas that are direct and they are of interpersonal nature with assault or threat. So these types of traumas disproportionately contribute to the risk of PTSD. The trauma type also contributes to different to the effects on broader types of psychopathology. So we can account the differences in trauma, so looking at no trauma, non-complex trauma, and complex trauma. And by complex trauma, we mean traumas that are of interpersonal nature, which, like we just said, is associated with greater PTSD risk, but also tend to happen in childhood and repeatedly over time. So with these types of traumas that are complex in nature, we see that we have greater complexity of psychopathology that we can measure in different ways. We can measure it through a continuous general psychopathology factors. This is almost like counting how many symptoms of different disorders people have. And you can see that the amount of general psychopathology is much higher in those with complex trauma, not just compared to those without trauma, but also compared to those with non-complex trauma. And similar patterns are observed if we count the number of psychiatric diagnoses that we make, and if we look at each single individual type of diagnosis. So certain types of psychopathology, of traumas, particularly this complex trauma, is associated with more complex psychopathology as well. And we need to really assess not just the exposure to trauma, but the characteristic of trauma, as well as the presence of resilience factors. So for that, I want to compare with you two scenarios. One where we have a witness accident as a type of trauma, which only happens once. And that happens in the context of supportive family environment and the continued engagement in normal daily activities. So in this case, it's very likely that the outcome of that traumatic experience will be positive. And we can compare that to this other scenario where instead the trauma is of interpersonal nature. It might have occurred multiple times. It may be ongoing. It may be related to grief and separation. And beyond the trauma, we might have a loss or relative loss of resilience systems, whereby, for example, parents were also involved in the traumatic experience, or they may have their own psychopathology. It may be associated with displacement and disruption of routines. And so this is a condition where it's not just about the trauma, you see, but the combination of the trauma characteristics and the resilience structures makes it more likely that children and young people will develop PTSD and other types of trauma-related psychopathology. And so building on the epidemiological work in the UK and thinking about different scenarios is also consistent with the many observations done in epidemiological studies in Ukraine, including this one published last year, where if we look at rates of clinically relevant psychological trauma, you see here that both in adolescents living in still Ukraine and adolescents living abroad, we have very high levels of PTSD, higher than the ones that we, of course, have observed in the UK, and compatible with the idea that beyond the trauma, there are other psychosocial factors that need to be addressed to reduce and mitigate these effects. So this was a description of PTSD at a clinical level. And now I wanted to introduce the evidence base for treatment of PTSD. I guess the first question to ask in this context is, what exactly is that we want to treat when we treat PTSD? And so there have been, in many ways, opposing views on whether what we try to treat is to mitigate some outcomes related to the objective experience of the trauma, so the amount of distress, for example, related or other objective measures, or instead the more subjective appraisal that we have of the events. And this is part of the research that I've been conducting with the colleagues from the US, Professor Kathy Whedon, who has built a remarkable and unique cohort over the years. So in 1986, she has identified a cohort of individuals in the US for whom she was able to identify childhood records of trauma, in this case, childhood maltreatment, from 1967 to 1971. And so, as you can see, she has identified 900 court-substantiated cases of abuse and neglect, and a group of 667 demographically matched controls. And what she has done was then to follow them up later in life, at about 29 years of age, to not only assess psychopathology, but also ask about their individual memories and appraisals about the childhood experiences. And so this resulted in this non-overlapping groups of individuals with objective as well as subjective experiences of trauma. So the objective traumas are the measures from the official court records, and the subjective measures are the adult self-reports of childhood experiences. And you can see here it's actually even broader at a statistical level. You can see that there is poor overlap between these groups. And so this allowed us to ask a question and to consider two alternative hypotheses. On the one hand, if psychopathology is more strongly associated with the subjective experience of trauma, then the self-reports will be associated with higher prevalences of psychopathology. On the other hand, if that was down to the objective experiences, the court records will be associated with higher prevalence of psychopathology. And what we observed is really consistent with the greater impact of the subjective experiences or appraisals on the risk of psychopathology. So those with only official court records had rates of psychopathology similar to those of controls, whereas those who had recalls had higher levels of psychopathology, whether or not they had official records. So what we try to do with treatment for trauma-related psychopathology really is targeting the subjective appraisals and cognitions that are related to trauma. And these are the three principal therapies that are used in interventions. So trauma-focused cognitive behavioral therapy, narrative exposure therapy, which really is another type of trauma-focused intervention, and then EMDR, or eye movement desensitization and reprocessing. And these interventions are evidence-based and have some common elements. So there are cognitive elements that aim to challenge unhelpful beliefs about the event. So, for example, they could be about the self. And we often see children and young people and adults who, after the traumatic event, might feel guilty, almost responsible for causing the traumatic experience. They might feel shame. They might have low self-esteem because of these experiences. And also the way they think about others. So reasoning around ongoing threats, for example, that they may perceive even when they're placed in safer environments. The interventions then also focus on behavioral elements that aim to reduce the avoidance of traumatic memories. So I said that avoidance is one of the three dimensions we assess when we look at PTSD, and really is a maladaptive coping strategy because it prevents the adequate processing of the memories. And so the behavioral strategies really facilitate the processing of the memories. And there are then more generic elements in the treatments that have to do with building emotion regulation skills and also focusing on relationships. With regard to trauma-focused CBT, which is one of the key, perhaps the best established interventions for PTSD, it has a number of elements that I will not be able to go into detail now in terms of our timing, but I wanted to at least share with you. So we typically start the sessions with psychoeducation and parenting to normalize the responses to trauma. We teach relaxation techniques so that children and young people may be more able to engage with the strong emotions that may be elicited in the context of trauma-focused treatment. We teach and talk about affect modulation. And then we start thinking about cognitive coping. So thinking about the relationship between thoughts, feelings, and behaviors, and reframing those unhelpful cognitions that we were just discussing. We then think about trauma narrative and processing. This is the more behavioral aspect, where we guide the child in creating narrative of the trauma to gradually process and integrate the experience. We then think about in vivo exposure where possible, so that we can support gradual real-life exposure to the trauma reminders to reduce their effects over time. And we think then about co-joint parent-child sessions to facilitate narrative inside the family and to strengthen communication. And finally, we think about enhancing safe and future development. So we teach safety skills to avoid effectively re-experiencing trauma. These treatments, I already mentioned, are evidence-based in that they are underwritten by key international bodies, including NICE here in the UK, as well as the International Society for Traumatic Stress Studies. There is very good evidence for their effects, and in fact, treatments that are trauma-focused, so treatment of PTSD, has some of the best results across diagnosis in children and adolescents. So if we look at efficacy, we see that there are multiple meta-analyses that point to the effects of the treatment on symptoms reduction. And these are effect sizes that are larger, for example, than the effect sizes that we would observe for depression or anxiety. There are meta-analyses highlighting the effect on response rate, so taking effectively the diagnostic label away. And importantly, these interventions are not just for the mild cases, as it were, of PTSD, but their effects are independent of age, sex, trauma type, baseline PTSD severity, or comorbidities, as well as in, the involvement of caregivers. We know, importantly, that, as I said earlier, often we have comorbid condition with PTSD, and we know that the treatment for PTSD often ameliorates, reduces the comorbidity also with depression and anxiety. And we are studying how these interventions might work in neurodivergent children and adolescents. A big concern traditionally has been that trauma-focused interventions may not be acceptable in that they raise very strong emotions, and there may be issues, either emotional issues with the patients or safety issues even. But research says otherwise. So we have observed that 1% of children and young people who engage in trauma-focused CBT show deterioration, compared to 13% of those who do not receive trauma-focused CBT. And also, we have very low rates of disengagement or withdrawal, even compared to other conditions like depression. And finally, more and more, we're finding solutions to scale up these interventions so that they can not only be delivered individually, but they can be delivered in groups and potentially digitally in the next few years. I wanted to add a slide on psychopharmacology, mainly to say that there is no evidence that psychopharmacology is effective for the treatment of PTSD specifically in young people. However, again, we have discussed that PTSD is often comorbid with other conditions, and of course we do use psychopharmacology to treat comorbid conditions at times, including depression, anxiety, but also neurodevelopmental conditions like ADHD. And finally, we are aware that there is use of sedatives and hypnotic medications, and this really can be concerning. And so our advice is that it can be used in the short term in a pragmatic way, but really requires active monitoring, and there is no evidence that it helps in the long term. So it may be something that can be used acutely at the beginning of treatment if necessary, but has no real space in the evidence-based treatment for PTSD. And to conclude, I wanted to highlight an important factor, that is that despite the severity, distress, and impairment associated with PTSD, we often miss PTSD in children and adolescents, even in the UK. So if we look at simply children who report trauma exposure, you see that the vast majority of them do not seek any mental health support. Only 10% seek support by a psychiatrist or a psychologist. And you might say, well, that may be fine because not all of them will develop a mental health problem. But a very similar scenario is also observed if we focus on PTSD. So again, you see that most young people who meet criteria for PTSD never sought support from a health professional, and only 20% of them in the UK sought support from a mental health practitioner. And of course, this only tells us if they have sought support. It doesn't tell us if they were correctly diagnosed or if they received evidence-based treatment. And we are doing much work on this, and the evidence really suggests that only a very small fraction of children and young people with PTSD in the UK are correctly identified and treated. And there is no reason to believe that the situation and the pictures are different in other countries where the health system may be even more overstretched than our own here in the UK. So it's really important to consider when thinking about a systemic approach to detection and treatment of PTSD, what the barriers to healthcare access might be. And these might be psychological barriers. There are very important psychological barriers that have to do, for example, with trauma-related symptoms or emotions and cognitions like shame and guilt. We may have cognitions of distrust and hopelessness based on the traumatic experiences. We may have behaviors like avoidance and inactivity that prevent engagement in healthcare seeking. We may have developmental challenges related to early age or neurodevelopmental delays that might bias reporting as well as engagement in treatment. There are cultural barriers, the limited mental health knowledge, the stigma around mental illness, and the concerns about being stigmatized by others. And finally, of course, there may well be several structural impediment barriers to healthcare access, including disruption of transportation, disruption of family and community networks, scarcity in clinical capacity in child and adolescent mental health, or the limited availability in mental health professionals and the rise in demand that might overwhelm services. So these are all barriers that is really important to map at a system level to try and facilitate the engagement with healthcare and the provision of adequate assessment and treatment. And pragmatically, what we typically recommend is to think about trauma screening, so to have a proactive approach, asking about trauma exposure. And it's important to remember that we want to ask about trauma exposure ideally to children and young people, not necessarily to parents, who may be familiar with events but may not appreciate how much the events might be perceived as traumatic by the children and young people. And in addition to the trauma exposure, of course, we want to also screen for the severity of symptoms. And these are just some of the common screening measures that we have used in multiple countries. And so I will stop here, just walk through normative responses to trauma, description clinically of trauma-related psychopathology, evidence-based approaches to treatment, and that important reminder that there need to be a lot of attention to barriers to accessing healthcare assessment and treatment as well. And I will leave some further readings for those of you who are interested in the topic and want to learn more. These are all free access. And I will thank you for your attention.
Виводите? Ще раз всім добрий вечір. Зараз будемо задавати питання, їх доволі багато. Зараз я прийду в початок питань. Так, зараз хвильку. Питання від пані Марії Літвиненко. Дитина 7 років з прифронтової громади боїться залишатися в класі з дітьми, боїться, що мама її покине, а на вулиці з друзями спокійно залишається без мами. Що порадити?
Sorry, I didn't quite capture all of it. So the child is distressed in the classroom, but not in the streets?
Дитина 7 років з прифронтової громади боїться залишатися в класі з дітьми і боїться, що мама її покине, а на вулиці з друзями спокійно залишається без мами.
Yeah, it's in terms of these clinical pictures, there could be a number of reasons why that might arise, of course. So it's hard to give one straight answer to it. I would probably, given these concerns about separation is not pervasive, it's not experienced in different contexts, but seems to be specific to school. I guess initially I would be interested to understand what is about the classroom that makes the child have these thoughts, unlike when he's in the streets. So it may be that he had some experiences in the classroom that might increase distress and therefore reassurance seeking from mothers. But it's hard to say without more knowledge of the child and the context.
Пані Уляна Заболотна питає, чи є різниця між дитячим підлітковим і дорослим ПТСР?
Yeah, there are differences, and I suppose if we look at a developmental continuum, of course, the presentations in adolescents, particularly older adolescents, will be quite similar to the presentation in adults. What tend to be difference is the presentation in younger children, particularly preschool children, and of course, children who may have learning difficulties, so whose developmental age might be different and younger compared to the chronological age. So what we may observe in younger children is that their the symptoms that they manifest are a bit different compared to the symptoms of adults, and particularly they may not be able to report a lot of those cognitions that we were discussing. So the assessment might have more to do with observations, direct observation. So they might, for example, be observed reenacting some of the traumatic experiences or being very highly avoidant. Or they may have some regression. And part of the assessment and the treatment for that reason has to be through parents as well. But I guess in terms of considering the differences, we want to consider the level of development, the general level of development, to understand whether they are, for example, able to have more abstract reasoning, and therefore they can report and realize some of these symptoms and report them to us.
Пані Світлана Арсенюк питає, для підлітків з аутизмом які особливості в лікуванні ПТСР?
Yeah, so there are, and there are many efforts in manualizing, so to have a common standardized way of addressing these peculiarities. In a similar fashion, they might have to do with more behavioral types of interventions compared to more cognitive type of interventions. It may be also that some of the materials that we use for sessions or psychoeducation is to be adapted so that, for example, there may be more figurative leaflets that explain the process visually rather than long descriptions that might be hard for autistic young people to access. But the fundamentals, I would say, are quite similar. And in fact, we work with many young people on the spectrum or diagnosed with autism in our clinic. And we have very good results even then.
Пані Михайлюк Оксана питає. Дитину змушували роздягатися на камеру. Дитині 8 років. Замкнута в собі, малює малюнки чоловічих статевих органів. Постійно згадує про цю подію. Це може бути проявом ПТСР? І як правильно надати психологічну допомогу такій дитині?
Yeah, it could be. I guess, so again, without assessing the child, it's difficult to give clear indications, but it could be. And I guess what I would highlight is that beyond this reenactment, it's helpful to understand what are the patterns and whether, for example, this triggers distress in the child, whether there is any other evidence of PTSD. So it could be one symptom, but of course the assessment needs to be broader and include evaluation of all the other dimensions and symptoms I was discussing earlier. But yes, it could be.
Пані Сидоренко Єлізавета питає, які чинники резилієнтності, на вашу думку, мають найсильніший захисний ефект для дітей і підлітків після пережитої травми? І як їх можна цілеспрямовано розвивати в клінічній практиці?
Yeah. So, as I was referring to earlier, the factors that have the strongest effects in fostering resilience really have to do with the individual perception, both of the trauma and of the environment around the child. So the main need is to, first of all, challenge some catastrophic interpretation of the events where possible, and to challenge some of those cognitions around, for example, shame, guilt, and so on. And that's really important. The other factor is to build resilience around the child. So the ongoing perception of threat that is driven by the memories in many ways can be mitigated if the environment remains a predictable and, as much as possible, safe environment for the child. So that, for example, it's really important as much as possible to ensure that the child continues engaging in daily routine and continues with positive activities that they were doing before the traumatic experience, so that there is no disruption of the world around the child, but it's possible to sort of single out that experience as a bad experience that had happened, but has no pervasive consequences on the environment around the child.
Пані Ольга Шніт питає, як, на вашу думку, найкраще адаптувати протоколи лікування ПТСР до контексту тривалої війни, коли люди одночасно мають і минулі травми, і постійні поточні стресогенні фактори?
Yeah, that's a very difficult question to answer because we don't really have much evidence on exactly how to do this, right? So most of the evidence base in PTSD comes from studies where the child had a traumatic experience that had concluded, and then receive treatment. Yeah. So there are many people who are considering how exactly to adapt what we know from treatment to the current situation, whereby the trauma effectively could be ongoing, right? Or it could be re-experiencing of trauma. And although there is no strong evidence base, I think the approach is that we need to discriminate and separate what is driving the PTSD and what might be making it worse, if you like. So even in the context of potential risk, that ongoing risk will make it more difficult to challenge the assumption that, for example, the world is unsafe, or to challenge that ongoing perception of threat, right? However, it's still possible to address some element of PTSD and therefore mitigate the presentation of PTSD if we address the memory of the original trauma, right? So if we can reduce the impact of those memories, progressively the perception of threat could be mitigated. And so we navigate then in that difficult line between trying to support a perception of safety by reducing the impact of memories, and then, of course, living with the reality that threat is there. So with the treatment, we can focus on treating past experiences. Ongoing experiences will make it worse because they tend to confirm, right, that the past might happen again. But there is still space to work with those specific memories in treatment. So it's a hard question to answer, unfortunately, but I know we and many others are really trying to consider how treatments can be adapted given the situation.
Пані Альона Цвіткова питає, чи може передатися ПТСР, негативний досвід, у спадок майбутньому поколінню?
So it is, again, a very good and complex question to address in just a few minutes. But we can consider what it means to inherit PTSD, right? So if we mean a inheritance through genetic or epigenetic factors of the distress that is experienced by parents to the children, I think we have some evidence that that might be possible in some models of humans. But at the moment, the evidence in humans is extremely limited. And we can find a number of alternative explanations for the idea that PTSD can be inherited biologically from one generation to the next. If instead, by inheritance, we mean that the traumatic responses, so the PTSD in parents, somehow can increase the risk of PTSD in young people, that may be more plausible in terms of providing the context, right? So children are, first of all, exposed to, if they are exposed to the same environment, may be themselves exposed to some traumatic experiences. So it's not an inheritance, but is more the fact that there are common risk factors, right? And also the other element of it is that children learn, of course, a lot from parents and might adapt and adopt some similar patterns of behavior. So they may learn, for example, that avoidance is a strategy that their parents use. in the context of traumatic reminders and may be more likely to use avoidance themselves, right? So at this psychological level, I think we do have evidence, and we have evidence that when treating the child, we need to think about the family overall, right? Because if parents have their own mental health problems, they may well struggle providing the children with an environment where the child might continue feeling safe.
Пані Юлія Черненко питає, як щодо арт-терапії ПТСР у дітей та підлітків?
So, sorry, I'm not sure the question.
Арт-терапія.
Art therapy. Yeah, so it's interesting. So art therapy is not an evidence-based treatment for PTSD. So in terms of the effect sizes that we might observe with trial, this is not something that has been recommended by any of the international reports.
Наступне питання, не знаю, чи мене чутно. Андрея, чутно мене?
Yes, I can.
В нас картинка просто зникла, але якщо Андрея мене чує, то і перекладачі мене, мабуть, чують. Пані Лариса Цілінко питає.
Yes.
Дитина 11 років, 3 роки тому отримала кілька травмуючих досвідів. Окупація, обшуки в її будинку, обстріли. До цього часу інколи 2-5 разів на рік перед сном згадує негативні події та сумує з цього приводу. Якої допомоги достатньо в такому випадку?
So if I understand, there were some potentially traumatic experiences, and this child is reporting re-experience, so some memories, basically. So I guess I would want to understand, first of all, how these memories are triggered. So if these are things that in some ways or another, the child things, for example, to remember some situations they were in with the family, or if these are the intrusive types of memories we were discussing. And if they are the intrusive memories, then as we were discussing, then we need to assess for other features, right, before potentially making a diagnosis of PTSD. So not only thinking about the intrusive nature, but potentially the avoidance and the linked physiological hyperarousal to these memories. So if then these criteria are met and the colleagues think about a diagnosis of PTSD, I guess the first line of treatment in terms of the best evidence treatment would be with trauma-focused CBT that can be delivered both individually as well as in groups.
Пані Аліна Кринець питає. Хлопець 15 років попав у вересні 25-го року в автокатастрофу, де загинув його найкращий друг. Закрита черепно-мозкова травма, 5 днів у комі, через 10 днів почав розмовляти. Наразі нога в апараті Єлізарова, психіатричний діагноз – маячний шизофреноподібний розлад. Після фармакотерапії пропали галюцинації та голоса. Наразі в'язкість когнітивних процесів, сильна втомлюваність. Психіатр прописав EMDR та TF-CBT. На вашу думку, коли рекомендовано потрібно розпочинати терапію? Зараз виражена дереалізація. Каже, здається, що це все сон.
So I'm not sure where the schizophrenia diagnosis came from, but so I guess so that would be my first thought, right? In terms of understanding whether there was mainly a diagnosis related to the traumatic experience, or there were concerns about psychotic disorders and experiences. And so I would prioritize the assessment of psychosis, and in case psychosis or schizophrenia specifically are diagnosed, start treatment with antipsychotic medication and psychological interventions for psychosis. So if instead the psychosis or schizophrenia was not identified after initial concerns, then it is possible then that the dissociation and derealization reported might be part of PTSD, right? So there is, I suppose, initially a differential diagnosis between psychosis and PTSD, which could be done not just based on the exposure to the event, but also thinking about cognitive deficits, prior psychiatric history, family history, and also the phenomenology of the presentation. So thinking about negative symptoms, for example, versus intense distress, and also the relationship between the distress to specifically traumatic reminders, right? So there is that exercise of differential diagnosis that needs to be prioritized. And then depending on whether either are present, then I guess there is a rationale for treatment. Of course, psychosis and PTSD can co-occur. And if that's the case, the timing for the interventions, of course, is more challenging. I would say still to try and address the traumatic experiences, and then consider treatment for psychosis, depending on the ability to engage in that treatment.
Пані Ольга Піскорська питає, чи справляється з ПТСР гіпнотерапія?
Yeah, so a bit like for our therapy, it's not something that in trial has been studied and seen to be effective at a population level or at a sample level. So it's not something I would recommend based on the fact that we don't have evidence that really works. It might be helpful in the individual cases, but as a in terms of strength of the evidence base, that's really not there. Our therapy, on contrary, I would say, and I was interrupted, is not an evidence-based treatment, but can help still with the engagement. And that's really a very important initial phase. So although I wouldn't think that our therapy is a treatment for PTSD, can be used strategically, if you like, to improve the engagement, particularly initially, in a therapeutic relationship that then might lead to more evidence-based interventions for PTSD.
Пані Юлія Черненко питає, через який проміжок часу після травматичної події можна діагностувати ПТСР у дітей?
Right. So typically we think about a diagnosis of PTSD if the symptoms that I described earlier are present for more than a month. That's the definition according to the DSM-5. ICD-10, so that's or 11, is more lax and talk about several weeks. But I would say generally after a month or a month and a half of symptoms that are distressing and impairing, then we can consider a diagnosis of PTSD.
Пані Альона Цвіткова питає про фантомні болі у військових. Як з ними працюють?
Sorry, I didn't catch that. What symptoms you mean?
Фантомні болі. Фантомні болі у військових.
Phantom pain. Yeah. I'm not sure I can answer that question. I apologize.
Окей. До того кейсу, про який Андреа вже відповідав, про хлопця після аварії, є тут два коментарі. Чому ставили психоз? Тому що були голоси і галюцинації, а до аварії був здоровий і приймає антипсихотики.
Sure. Yeah, so I would say, it can be hard. So I would be cautious in going down the way of psychosis, because it can be hard to do differential diagnosis. And reports of hearing voices are, of course, potentially suggestive of psychosis. But we have seen many cases where the psychosis was misdiagnosed, because what really they were talking about were the reliving experiences. So they were hearing basically voices of people, potentially, right, from that traumatic experience. And so just that report of hearing voices could be entirely consistent with psychosis, but could also be consistent with PTSD. So by itself, would not necessarily be diagnostic, and needs to be assessed carefully. And on the other hand, treatment with antipsychotic, of course, will lead to reduction in distress, because antipsychotic are very heavy sedatives. So it doesn't necessarily give a pragmatic diagnosis given response to those medications.
Я задам ще 3 питання, і на цьому будемо завершувати. І так, пані Наталія Маслакова питає, чи можна працювати пісковою терапією з підлітком або дорослим з ПТСР? Я так розумію, мова йде про пісок, правильно?
Oh, yeah. Yeah. So, again, I think it's something that might help with engagement, potentially, but in terms of evidence base of treatment outcomes with such an intervention, I don't think that there is anything really strong. So I would not really advise that intervention unless we use it again for the very initial stages for engagement.
Пані Габріела питає, з дозволу, у випадку коморбідності ПТСР та РДУГ, як відрізнити, яка симптоматика до чого належить, і яка була стратегія лікування?
Yeah, that's a very good question. And again, a bit like we were discussing for ASD and psychosis, these are comparatively recent questions. So it's quite striking, actually, that for many years, epidemiological studies and treatment studies for PTSD really only focused on normally developing children. And it is only now that we are developing a greater sensitivity to the issues of neurodiversity that we're starting to ask these questions. So there is no guidelines on how to go about it. What we do clinically is to consider several factors. So to mention a few, well, first of all, ADHD and PTSD can be comorbid, right? They could be both present rather than thinking about a differential diagnosis. But however, it's important to consider differential diagnosis when both might be present. And so what we typically do is trying to, first of all, develop timelines, right? So was the presentation of PTSD symptoms triggered and only present after the exposure to traumatic event? Was the presentation with ADHD present before the traumatic event? Because, of course, with ADHD, we typically want to identify that condition from early in life. Another aspect is the pervasiveness of the symptoms. And so we might be considering, for example, that PTSD disrupts attention. But when PTSD does disrupt attention, is typically because of the memories. And the memories are more often triggered by contextual reminders. So I would be asking, for example, if deficits in attention are mainly experienced in one environment that is very different from the context where the trauma has occurred, or whether the attention deficits are mainly or only present in the context of traumatic reminders that might trigger those memories. It might still be difficult, and it might be valuable to potentially do some pragmatic trials with even medications for ADHD if the differential diagnosis is unclear.
І останнє питання сьогоднішнього вебінару від пані Олени Плескань. Чи є якісь практичні поради для батьків, як виховувати дитину більш стресостійкою, щоб в майбутньому при травматичному досвіді не виникнув ПТСР?
Right. I think so it's a very good question. I think it's hard to think about building. It's not necessarily even resilience, but what we would call inoculation, basically. So that is really hard, and we don't really have a good evidence base on how to make people inoculated, as it were, to future traumatic events. Partly because, again, it is the subjective response to the traumatic event that drives psychopathology. What we know more is what parents, if you like, can do in the context of traumatic events. And so what we typically recommend to parents is, first of all, to give time to children so that they can potentially recover from the normative responses to traumatic event, but equally, they feel that the environment is open for them to express concerns about, for example, their memories, if they have them. And so it's important to give them time initially to recover from those initial normative responses, but then space to talk about the events. We don't need to force them, but to make it clear that if they ever want to discuss those, the parents are open, basically, to this. As I said, what is really important to do is to think about the perception, right? So how do we, as parents, make sure that our children feel as safe as possible? The easiest thing to do is really to maintain their routines. So it could be mealtime, bedtime routines, or visiting families and friends, or encouraging them to keep going to school, right? Any of those routines builds predictability, and that predictability in turn can foster the perception of safety, which is really important, of course. We can make sure that we control, in some ways at least, the access to news and social media that sometimes tend to expand, right, the perception of threat. And of course, I mentioned it earlier, it's really important for parents to think about their own responses to events, particularly if they're joint events, so that they can model for the child what a good response to those events is, which typically is accepting that this bad event have occurred, but these bad events need not change the environment of the child or the future of the child. So all these aspects are really quite useful for parents to reduce and mitigate the effects of traumas on future outcomes.
Я дуже дякую, Андрея, за цей вебінар. Дуже дякую всім, хто нас дивився. Нас було більше, ніж 400 людей на цьому вебінарі від початку до кінця. І так ми надійшлимо презентацію. Там люди питали про презентацію. Ще раз хочу наголосити, що на каналі доктора Булавінова будуть викладені як українська версія з перекладом, вона вже там є, бо ви її вже дивились, так і буде викладена англійська версія і для тих, хто любить дивитися англійською. Дякуємо вам за те, що ви нам присвятили свій вечірній час в такі складні, холодні, темні часи. І дуже дякуємо, Андреа. Всім тихої ночі.
My pleasure. And